Hello everyone. Today we'll discuss fluid resuscitation in hypovolemic shock. Typically, crystalloids, colloids, and blood products are used to reverse hypovolemia. In this lecture, we'll learn how to choose the type, amount, and the rate of resuscitation fluid. Hypovolemia changes distribution of IV fluids, so it's important to understand these changes when you give fluids to these patients. In the previous lecture, we understood how isotonic crystalloids distribute in the system. They distribute between stressed and unstressed compartment. Some of it will leak into the interstitium, and it will accumulate into the interstitium between the aqueous phase and gel phase. Some of it will return back via lymphatics, and finally, there will be loss in urine. Please review my earlier lectures on this topic for a better understanding of these processes. So in this lecture, we'll understand what happens to all these processes in hypotension from hypovolemia, for example, in hemorrhagic shock. And then we'll learn how to give IV fluid in these situations. We'll not discuss the inflammatory cause of a hypertension, for example, sepsis, as inflammation causes additional changes in the parameters on the top of that what we'll be learning today. Also, in a rapidly exsanguinating patient, you would like to replace lost blood with the blood products and avoid crystalloid, for example, patient with trauma. So let's look at how hypotension affects your stressed and unstressed compartments. Hypotension results in stimulation of your sympathetic nervous system activation and renin-angiotensin L-RON system. Both of them cause vasoconstriction, which tends to maintain the mean arterial pressure. Activation of these two systems also result in venoconstriction, which recruits blood from the unstressed to stressed compartments. You know that the 70% of the systemic blood volume is in the veins, and experimentally, when you cause venoconstriction, you can shift up to 1 to 1.5 liters of blood from venous to arterial compartment. So if you look at this diagram, the estimated blood loss as you increase from 500 to 1.5 liters, the venoconstriction increases and helps maintaining the mean arterial pressures. In the same regard, you can see that the heart rate is gradually increasing. So during the early phases of hemorrhage, there is not much alteration in cardiac output. And this is really important because that tells you that earliest sign of hemorrhage is a tachycardic response and not hypotension. In fact, very early in the hemorrhage, patient may even be a bit more hypertensive. The clinical importance of this finding is if you have got active bleeder whose heart rate just went up, that means became more tachycardic, that patient is most likely rebleeding. Other things that make you suspect active bleed like hemoptysis and hematochezia are not always present. Hypertension takes time, melena takes quite a long time, and a drop in hemoglobin or hematocrit also takes time. So tachycardic response is the quickest way to figure out if there's an active bleeding going on. Let's look at the effect of hypotension on net capillary filtration. So as you become more hypotensive, your peak capillary drops, and that drops your rate of net capillary filtration. This is one of the safety factors that your body does to maintain your intravascular volume. So as your peak capillary pressure drops, your net hydrostatic pressure gradient drops, and your net filtration drops as well. One of the things to note is that the outward flow is decreased and not reversed, as we learned in our modified Starling principles. This is a diagram which compares your mean arterial pressure to net filtration, and you can see that net filtration drops as your mean arterial pressure gets lower. Therefore, the crystalloid can remain intravascularly for a longer period of time when you give these to hypotensive patient because of decreased filtration in the capillaries. And this brings two important points. First, you can give crystalloid to correct for hypovolemia in early hemorrhage with a good blood pressure response, as these will last much longer. Colloids will certainly last longer than the crystalloid. So if you need to be volume conservative, it's okay to use colloids like albumin. And here you have to understand the argument between use of crystalloid and colloid. Understand that the main management principle in hypotension, which will govern the final outcome, is the correction of underlying etiology. In hemorrhage, even though colloids can last much longer than the crystalloids can last sufficiently long for you to control the bleed, and that's what you are exactly looking for. If you don't control the bleed, it doesn't really matter if you give colloids or crystalloid. On the same note, understand that things are very different if the patient is rapidly exsanguinating, for example, in a trauma patient, where you need to stabilize your patient with blood products and not with colloids or crystalloids. Let's look at the effect of hypotension on lymphatic function. In the previous lecture, we learned that the lymphatics are active pump and not passive, as we used to think before. The lymphatics are endowed with multiple receptors like alpha-1, beta-2, and muscarinic receptors. Stimulation of muscarinic and alpha-1 adrenergic receptors result in increased lymphatic activity, while the activation of beta-2 adrenergic receptor results in inhibition of the contractility. So in hypovolemic shock, when you give norepinephrine or phenylephrine, or intrinsic production of these two molecules will increase the frequency of contraction and decreases the diameter of lymphatics via activation of alpha-1 adrenoreceptors. Therefore, hypovolemia results in increased lymphatic return. This will be slightly different when you talk about sepsis, as we learned in the previous lymphatic lecture that when inflammation sets in, your nitric oxide pathway is stimulated, which is an inhibitor of lymphatic function. This study looked at the lymphatic activity with blood loss, and you can see that there is increased lymphatic contractility and increased lymphatic flow when these animals were bled. And this is really important because this increased lymphatic contractility will help replenish the blood volumes. So there is 2 to 3-fold increase in thoracic blood flow in the first hour after rebleeding, replenishing around 30% of the total blood volume, as seen in this figure. You not only lose fluid, blood, and the coagulation factor, you also lose protein in the hemorrhage. And from the previous lecture, we have learned that most of the albumin in human body is in the interstitium. And as some of these fluid returns back from the interstitium, it replenishes your serum proteins. So for example, in the study, around 7.8 grams of proteins were lost by hemorrhage, and about half of it was regained back in 4 hours. In 24 hours, more than twice of the protein lost in the hemorrhage was regained. And looking at the same study, you can look at the hematocrit, and it's very interesting that hematocrit takes a very long time to equilibrate, and sometimes it takes many hours. And this is really important when you have a GI bleeder, is do not rely on hematocrit in the early phases of hemorrhage, because hematocrit lags behind hemorrhage. And you can see that in this figure, it took quite a long time before hematocrit stabilized. So when you order Q6HNH, it's not a good indicator if someone is bleeding acutely. It's more of a reactive response and not a proactive one. So understand that the hemoglobin drop is disproportionately low in early bleed, and it will equilibrate after many hours. We have discussed the effect of hypotension on urine output. In short, urine output drops because of autoregulation, angiotensin II activity, and your tubuloglomerular feedback. Please review my earlier lectures on all these three to understand more. These are all the physiological changes that happen when you lose blood. So understand that a normal looking blood pressure can fool you into thinking hypovolemia or hemorrhage is not severe. Before your patient reaches a state of hypovolemic shock, their body has been compensating, and this is why they decompensate rapidly after a certain point is reached. They are possibly at the end of their rope. So it is very important for you to know where your patient is on this spectrum of blood loss or hypovolemia. One of the clinical takeaway from this figure is if your patient has required pressures due to hemorrhage, they possibly have lost at least 20 to 30% of their blood volume. So make sure that these patients need very close monitoring. Obviously, exception is if they have concomitant septic or cardiogenic shock. This is a very interesting study by Hahn and its colleague. They studied the various parameters that we discussed before in real time by bleeding these volunteers. V1 is your intravascular compartment, V2 is your interstitium, KT is your capillary filtration, and KR is your loss in the urine. They bled these volunteers 450 and then 900 ml and measured all these parameters. You can see that the net capillary filtration KT drops as more blood is withdrawn, and same happens with your renal losses. Your interstitial volume decreases so as to replenish your intravascular volume. You can see that the intravascular volume remains constant before it starts dropping off when more blood is withdrawn. If you give fluid in these patients, you can see as you increase the amount of bleeding, the half-life of the ringer lactate keeps on increasing. This is another study which looks at the hypotension from anesthesia drugs, and they found that elimination of crystalloid fluid is greatly retarded during general anesthesia, due to reduction in arterial pressure. And you can see that the half-life of normal saline increased from 50 minutes to 110 minutes. So T-half of the crystalloid, as we learned, is usually around 20 to 40 minutes in conscious humans, but it can extend 80 minutes or longer when you have dehydration or blood loss. Longest T-half of the crystalloid have been measured between 3 to 8 hours, and that have occurred during surgery and general anesthesia with mechanical ventilation. So let's look at the colloid such as albumin. This was an interesting study where they hemorrhaged rats around 8 ml per kg and resuscitated with 5% albumin and ringer lactate. And you can see that even after 4 hours post-resuscitation, the plasma volume was similar in both cases. But that was a rat study. Let's look at the human trials. This was one of the interesting randomized control trial where they treated major hemorrhage with ringer lactate, 5% albumin, and 20% albumin. These patients were undergoing cystectomy and were under anesthesia. There were 14 patients in each group, and you can see that the blood loss was around 700 to 800 ml, and they gave 2.8 liters of crystalloid in ringer lactate group and around 2 liters of crystalloid in 5% and 20% albumin. So that would mean that they're comparing 800 cc's of ringer lactate with 900 cc's of 5% albumin and 200 cc's of 20%. And you can see that the fluid balance in the first 24 hours was pretty much similar. And this was the blood volume change that they noted with time. Since around 700 to 800 cc's of blood was lost, the red line shows the amount of plasma volume if there was no experimental fluid given. There are few interesting observations in the study. First, at 4 hours, around 50% of ringer lactate remained intravascular. We learned from the previous lectures that only 20% of ringer lactate should remain in the intravascular compartment. And you can already see that more of the ringer lactate remains intravascular because of the hypovolemia. And 100% of 5% albumin remained intravascular, which is very interesting. Other interesting thing to note that similar amount of ringer lactate and 5% albumin was used. So that might explain why the blood volume change was much lower. We know that you need around 3.5 to 4 times higher volume of ringer as compared to the albumin. Next interesting thing was the clinical parameters such as cardiac output, mean arterial pressure, and central venous pressure. And there was no difference between either of the three groups. This would lead to conclusion that colloids are certainly better at increasing the intravascular volume status than crystalloid. However, crystalloids do tend to remain in the intravascular period for much longer period of time, and the clinical parameters such as cardiac output, MAP, and CVP are possibly not as much affected by the choice of fluids. And this is where you have to think about which is better, crystalloid versus colloid. There have been 5 randomized controlled trials so far comparing crystalloid and colloids, and they have all failed to show difference in mortality in ICU patient. And the question is, why don't you see that difference? One of my thought is this because both achieve similar clinical parameters, even though volume used by colloids are much smaller? So when you read these studies, try to see the differences in the fluid volume between the crystalloid and colloid so that you can make mind of your own. So let's summarize what we have learned visually. When you develop hypovolemia, the first change that happens is activation of sympathetic nervous system and renin-angiotensin aldosterone system. And these activation, along with autoregulation and tubuloglomerular feedback, decreases urine production. These also cause vasoconstriction so as to maintain tone and the perfusion pressures. And this results in decreased net capillary filtration. Activation of the system also results in venoconstriction, therefore recruiting fluid from your unstressed to a stressed compartment. There's also recruitment of fluid and albumin from interstitium via increased lymphatic return. So let's see how to give fluid to these patients. When you give crystalloid to these patients, 2 things happen. First, your activity of your sympathetic nervous system, renin-angiotensin system reduces, and fluid tends to maintain the tone and the blood pressure. And this can be observed by looking at improving tachycardia. So the main goal of crystalloids or IV fluid in hypovolemia is to maintain the perfusion of vital organs. You can use either crystalloid or colloid, and both of them should give you enough time to fix the bleeding. If you're worried about giving too much volume, it is okay to give colloids like albumin. As you keep on resuscitating, the net filtration keeps on increasing so as to lower the half-life of your crystalloid and colloids, so you won't get the same bang for the buck for the same volume. So second goal of giving fluid in this patient after you have maintained the perfusion is to replenish some of the compensatory mechanisms. And this is important because if they rebleed, they should be able to tolerate fall in blood pressure much better. However, if you keep on giving more fluid, accumulation of large amount of fluid in the interstitium will break up the interstitial matrix and create high compliance situation. One of the things that experiments have shown that when you give somebody small amount of crystalloids, most of this crystalloid will be limited to plasma volume, because for small volumes, the interstitial fluid matrix has too low a compliance to permit volume expansion. And this is really important because you want your fluids to remain intravascular for the longer period of time and not leak into the interstitium. And as these patients get more fluid overloaded, the aqueous phase of your interstitium opens up, and this makes it easy for the fluid to leak out of the capillaries. So avoid over-resuscitating your patients. Similar physiological changes can occur if you give fluid very rapidly. In this experiment, they gave around 25 ml per kg of ringer lactate at different rate to a normal person. And you can see that the percentage of infused fluid that remains intravascular is also dependent on the infusion rate. Fast rate of infusion fluid has been shown to damage glycocalyx. So your IV fluids can last longer if given slowly. However, if your patient is crashing and becoming hypotensive, make sure that you give them fast bolus, because that will result in more intravascular volume increase than a slow fluid bolus. So use fast boluses for rapidly deteriorating and hypotensive patient. And once your patient is stable, and if you think that patient needs more fluid, give it a little bit more slowly. Same principles will apply when you're infusing albumin or blood products. Second, don't target normal blood pressure in hemorrhagic shock, because that increases your rate of rebleeding and also to get most of your IV fluids. A MAP of 55 to 60 is okay till you get definitive control of bleeding. There are certainly exceptions to that, which include patients with traumatic brain injury, acute coronary syndrome, elderly with chronically elevated blood pressure, etc., where you need higher mean arterial pressure for organ perfusion to prevent damage to the organs. So the bottom line of resuscitating a hypovolemic shock is to maintain just enough perfusion with your IV fluids to prevent end organ damage while taking steps for definitive control of bleeding. So how is hypovolemia from hemorrhage different from dehydration? And you can review this study, which compared the kinetics of ringer lactate solution in dehydration and hemorrhage. And they found that if you're aiming for euvolemia, to correct a dehydration of 1 liter, you require around 1.2 liters of ringer lactate and around 0.9 liters in next 1 to 2 hours, while the hemorrhage of 1 liter will require replacement of 2.4 liters and around another 1.2 liters for another hour to maintain the euvolemia. The half-life of IV fluids is certainly much longer in hemorrhage than dehydration. Now you have got some concept how hypotension affects the fluid distribution, and you can use this information to individualize the fluid resuscitation in hemorrhagic or hypovolemic shock. These are very important references. I recommend you to go through all 4 of them. Thank you.